I'd like to welcome our audience to our series of Carestream Talks. Today's topic is going to be pediatric imaging. I'm Charlie Hicks. I'm the General Manager of our Digital Medical Solutions at Carestream. And today we're going to be talking a little bit about dose and image processing as it relates to pediatrics. Today joining me is Dave Foose. He's our Senior Director of Research and Innovation. So Dave, maybe you could give us a little background?
Sure. Thank you, Charlie. My background is in radiation physics and digital image processing. And together with my team in the research labs at Carestream, we have been focusing for a number of years on the optimization of image quality and dose for imaging children.
Now, Dave, both you and I have children. They're grown up now, as you can tell by my gray hair. Oh, by the way, congratulations on your daughter's pending wedding.
Thank you, Charlie.
Yeah. So I imagine, we spend a lot of time at pediatric offices, unfortunately in emergency rooms, some radiology departments. Both our kids were very active. And I imagine a lot of the technology has changed over the years, but some of it's still the same. But could you talk about some of the things that have changed since our kids were growing up?
Sure. Well, today the state of the art is imaging with, for projection X-ray with digital flat panel radiographic detectors. And that's different from maybe what you remember from when our kids were small, where screen film systems were more prevalently used. And then the migration, sort of a transition step through computer radiography and now to flat panel digital radiography. With digital radiography and the latest state-of-the-art systems, the image quality per dose efficiency, the dose efficiency is very high, which means that very good quality images can be captured at a lower dose versus film systems in the past. Okay. and CR.
So lower dose, but I also assume that it's improved the image quality, maybe suppressed the noise some, enhanced the detail?
That's correct. In fact, the systems today, these digital radiography systems, are characterized oftentimes, at least the detectors, are characterized by what's called the detective quantum efficiency, which is a surrogate name for the signal-to-noise ratio performance of the acquisition device. And the signal-to-noise ratio performance, the better it is, the lower the dose you need to get the same quality image, or alternatively, at the same dose, you can get a better quality image. Okay. Versus in the past.
Inside Carestream, we call our image processing engine Eclipse. Can you give us a little details about what we do with Eclipse as it relates to pediatric imaging?
Yes, let me just start by introducing what Eclipse is, and then I'll talk about the pediatric part of it. So Eclipse is the processing that's automated that takes the raw captured image from the DR detector and converts it into a display-ready form for interpretation by a radiologist or a physician. And that involves the application of a tone scale, which is a term that dates way back, but it's essentially the grayscale rendition of the image, coupled with multi-frequency processing, which does enhancement at different spatial frequencies to crispen edges, to compress dynamic range while still maintaining the detail contrast. So that's the basic underlying workings of Eclipse. What we do differently for pediatric processing is it is Eclipse processing, but for pediatrics, we have a different set of processing parameters, Eclipse processing parameters, that are optimized based on the patient age and the patient weight. Okay. As you can imagine, with children, they can be very small, or they can, a 17-year-old could be the size of an adult. So the processing parameters that are optimal for the different age groups across that age span, and also based on their size, coupled with their size, is a way that helps us to optimize the image quality at the lowest possible dose.
Okay. Inside Carestream, we have this concept of software advanced applications. Can you maybe expand a little bit and tell us how Eclipse actually uses that, and what are some of those?
Sure. These are what we call in our product, we call it companion views. And these are processing parameters and different algorithms, in fact, that leverage Eclipse, but they produce images that have a specific enhancement relative to a particular intended diagnostic purpose. So for example, we have something that we call tube and line enhancement. So with any patient that is in the intensive care unit, pediatric intensive care unit, neonatal intensive care unit, and also for adults, a lot of catheters are oftentimes placed in the patient for different purposes: feeding tubes, breathing tubes, and other types, pressure monitoring devices, and so forth. It is a critical requirement that the localization of the tube or line tip be performed when a new tube or line is placed.
Right.
And so these can be very low contrast and hard to visualize, and it may take the radiologist longer to be able to adjust the viewing to be able to see these things, or sometimes they're not readily evident at all, and they may make a mistake as to the localization. So the tube and line enhancement applies a set of parameters that enhance the frequencies that correspond to the size of these catheters, and it makes it much easier to interpret, and reduces the chance for any type of misinterpretation or a miss.
Okay. Now, we're talking a lot about image quality, but it seems like you can't talk about image quality without talking about dose. They're really tightly integrated. Would you agree?
I agree. In fact, they are they're inseparable. I think of when I think of image quality and dose, to me, I use the term dose efficiency. So it's what is your image quality for the amount of dose that it's applied, right? So you always want to maximize your dose efficiency, which is possible to do by having very high performing detectors, as I mentioned before, with high detective quantum efficiencies, which results in capture of images that have high signal to noise ratio, and coupled with the image processing that's applied that leverages that information content that's captured into a display-ready form that's optimal for viewing, that has low noise appearance, but yet has the interpretability necessary to perform the diagnostic task.
Okay. So you just mentioned detectors. So let's move on to detectors a little bit. I know recently Carestream released our new 2530 cesium detector. What's so unique about that when it comes to pediatric imaging?
So there are two aspects to it. First of all, the small form factor, the 25 by 30 centimeter, is a size that allows for the detector to fit into the trays that are associated with the isolettes that neonatal ICU patients are typically placed within. So the form factor alone is a convenience factor. But on top of that, and as it relates to image quality and dose, there are two aspects of the detector that are key. One is it has a very small pixel pitch. What that means is it's kind of, you can almost think of it as the pixel sizes. Okay. 100 micron pixel pitch translates to very high spatial resolution, which is necessary to see small, tiny features such as in these little babies. The other part of it is that it's a cesium iodide detector. So cesium iodide is the scintillation layer that converts the incident X-rays into visible light that are then captured in the detector plane. And the cesium iodide translates to very high, again, signal to noise ratio. So you have very good signal to noise performance, and you also have very high spatial resolution. And those are two critically important features when imaging small children.
So some great changes in the technology. You mentioned several. It's got to be confusing for our professionals out there, the staff, the radiologists, the technologists. What are some of the tools inside the software that can actually help them with their workflow?
One of the most prevalently used ways of tracking dose is the exposure index, and that recently has been something that's been standardized by work that's been performed by the American Association of Physics and Medicine and the IEEE. And so there's a exposure index now that's called the EI, and the exposure index isn't exactly dose, but it's relatable to dose. And for each captured image from the pixel data corresponding to where the anatomical region of interest is located, a calculation is performed that results in this exposure index value. And the exposure index is a measure of sort of like the average dose to the region of interest, to the anatomy that was exposed. And that's compared against a target index, which is set by each site, which represents their target for where they feel most comfortable in terms of the trade-off between dose and image quality performance. Because the lower the dose, typically the higher the noise appearance, which lowers the image quality in a sense. But the higher the dose, the more radiation burden to the patient. So these numbers, there's the target exposure index and the actual exposure index that's calculated for each patient image that's captured, can be tracked on sort of a population basis, and the site can see whether or not they're tracking according to what they're targeting or whether they're over or underexposing relative to what they're targeting.
It sounds pretty complicated to me. I mean, are there like a lot of manual calculations that are going on, or are a lot of these features automated for our
This
users?
is all automated.
Fully
Yeah,
automated.
it's all automated. The exposure index is calculated by through software that segments the anatomy and then calculates the exposure index for the based on the pixels that are contained within that anatomy.
Okay. Let's switch gears for a few seconds. We talked a little bit about the 2530, our small format detector. What are our options for, I'll call it longer length exams, maybe scoliosis or spine abnormalities?
Okay, so that's a good question as well. And long length images, which we call the detectors that we use for these types of exams, are typically used for imaging full spines and full legs. And so these cannot be performed by your standard 17 by 17 inch DR detectors unless you were to do a sort of a step and shoot type of an exam, which is how these exams have been done previously with DR systems. The consequence of doing a step and shoot type of an approach to attain either a full spine or a full leg image is that it takes a lot of time. Right. Because not only does the exposure have to be performed, but the detector has to be moved, and there has to be alignment and everything else. And in doing that, sometimes these images can take as much as 10 or more seconds to capture. So if you can imagine a patient, a child, and a sick child trying to be still for that amount of time, it can be quite a challenge. And the consequence of that is that there may be patient motion artifacts that occur because the images have to be stitched together to be able to get one full view of the spine or the leg from these step and shoot captures. So that's always been considered an issue. More recently, we've come out with what's called the DRXL. The L stands for length, right? So in the DRXL, what happens is it's a single shot long length image. So it's essentially a really large DR detector. And the advantage of that is that the total exam time now can be less than a second. And so the patient doesn't have to worry about maintaining either a breath hold or remaining still for this 10 or more seconds, which obviously is very difficult. And so that results in a fewer number of images that need to be repeated. And that, of course, means lower radiation, right? Every time you repeat an image, you're adding that incremental amount of dose to the patient. So now that is largely mitigated by the introduction of this DR long length imaging. Plus there's no image processing required to stitch a full length image together. It's really quite a brilliant breakthrough.
Yeah, I know when my kids were younger and they were having x-rays, I was always very concerned, especially as their reproductive organs were kind of maturing. I couldn't imagine sitting in front of a long length exam for 20, 25 seconds. So being able to do this exam essentially instantaneous must just be a tremendous benefit.
It is, it's huge. And as you point out, for scoliosis exams, it's prevalent in adolescent girls. And it involves imaging, with ionizing radiation, regions where the reproductive organs are located. So, this is, there's shielding that's applied, but you always want to avoid that to the degree possible. And these are patients that need to have, that need to be monitored and maybe get imaged every few months. So the dose can accumulate.
Dave, we're close to wrapping up. Before we do, I'd like to get a little off topic and talk about something that's really near and dear to me. And it's about the NICUs. You know, I've been in a lot of NICUs, and it always impresses me the amount of compassion and care that the staff give to these. I mean, we have parents there that are very nervous about their babies. You know, there's lots of attention and care that's got to be given. And there's this concept that gets brought up a lot, what's called image gently. Could you maybe expand a little bit on what you think image gently means to you?
Sure. Image Gently was an initiative starting, I'm guessing, 10, maybe more years ago, by a group of radiologists and also physicists that worked in children's hospitals with the objective of being able to find ways to image children at the lowest possible dose, but still, you know, meet the image quality requirements for the intended diagnostic task. And the term that is most well known that's associated with Image Gently is ALARA, and that stands for as low as reasonably achievable. Okay. And so the goal is to use the lowest possible dose, but still have sufficient dose to be able to produce a picture that is diagnostically viable. And in order to achieve that, the Image Gently movement brought to front and center the need for high performance digital detectors that have very good dose efficiency performance, as I described before, image processing techniques that could be optimized such that they could, when coupled with these high performance detectors, would further aid in the ability to lower dose or reduce noise appearance. And then also initiatives associated with dose tracking, as I described before, with the standardized exposure index method. So that all got standardized. Now all producers, vendors that produce projection X-ray equipment or ionizing radiation equipment that is used on children make use of these standard methods for tracking. So regardless of the vendor, if a hospital has multiple vendor systems, they can still combine that data to see where they stand from a dose tracking perspective.
Now, one of the other things I noticed when you get into a NICU, you know, it's very cramped. There's a lot of bassinets that are in there. And the sleeping patterns of infants is all over the place. So a lot of imaging equipment coming in there. I believe, you know, recently Carestream was really thinking about how efficient and how noisy it is to get this equipment in and out of NICU. So I know on our new Revolution, we spent a lot of times working on the sounds of the brakes, you know, all the clicks and clacks of undocking and docking the system. And of course, our Nano system it doesn't even have a motor. So it's essentially virtually non-noise at all. It's completely quiet. It's also got a smaller footprint to get around there. And of course, you know, I also like the pediatric skins. Do you have any other favorites on those?
I personally like the one with it's the aquarium.
The aquarium.
Yeah.
If you look at that closely, that's actually my face in that little circle. Anyways, so we've talked a lot about technology. Maybe in closing, you could talk a little about what does it mean to our customers, you know, the staff in the facilities and the patients?
Okay, so that's an important question and multiple different perspectives on that. So for the radiographic technologists, who are the professionals that actually perform the imaging of the patients, to them it's all about automation, workflow efficiency, and consistency. And so our systems have features to help enable all of those to come to fruition.
Okay.
So the technologist feedback to us has been very positive with regards to the ergonomics and the workflow and automation aspects. There's the radiology administrative directors, right? So they are the folks that oversee the department, the equipment, the radiographic technologists. To them, it's important that the systems be cost effective as well as dose efficient, and that the technologists are satisfied with the with the use of the systems. And again, we get very good feedback in that regard with respect to our different product offerings. The radiologists are largely going to focus on the picture quality.
Right.
And they're also going to care about the dose efficiency as well. I mean, that kind of goes without saying. So for the radiologists, again, the feedback has been great. We've done many clinical studies with university hospitals, with children's hospitals, working on trying to optimize the look preferences for the images that come out of our systems that are pictures of children. So we have gotten very good feedback, again, from the radiologists on the performance. And the final types of folks that would have maybe a different perspective, or an important perspective, I should say, are the patients themselves and also the parents of the children that are sick and in the hospital. They want that imaging to be done in a way that's safe, that the performance is good, and that is comfortable for the patients. So again, I think our systems satisfy all of the needs of those different groups of individuals that I just described.
Couldn't agree with you more. I'm so proud of the work that Carestream's done in our pediatrics, especially around the imaging of neonatals and young adults. It's just some tremendous work. So, David, looks like we're out of time, so I do want to thank you. And for the audience, I hope you enjoyed this session, and I'd like you to be safe, and remember to always image gently. Thank you.